for babies in our country. You go to Bangladesh, you go to Pakistan, they have tons and tons of it, but we don't. So these are complex questions, how those bugs come, who remain, who go away, how it changes. And we have to have discovery, and once we have some discovery, we have to validate, as I'm saying. And so this is the Asian Institute Professor Ganguly was talking about. And after it is validated, there will still be a question, which is, okay, it works, it's beautiful, but can I take it to the right population at the right time? If we give probiotics to us, to 5-year-olds, doesn't help for me. We have to give it to the babies. If it is for elderly population, you have to give it to that population, and at the right price. If nobody can afford, then all this that we are talking about is totally useless. So we have to make sure that it is available. This is one of a very bright scientist, Prabhu Patil at IMTech, and I was fortunate. I was giving a talk and be part of during Gandhi Jayanti. This is the last thought I want to leave you with. We all do hypothesis-driven so far testing. We think this is going to happen because it is logical, then we try to prove null hypothesis. We know in statistics we try to disprove the null hypothesis, but there is much more than that. Now that era has gone, so you have to do something totally different. Think about Gandhiji. I never really cared as much about him until 5, 10, 15 years ago, 10 years ago, that he took the slogan that he had, that somebody slaps you, you show the other cheek, you will be able to win it. Is it logical? I mean, will you think of that if I tell you that, okay, you take a bacteria which blasts in your tummy and really gives you pain? Will you ever try that as a probiotic? No, you'll stay away. So it was totally counterintuitive. Nobody would have thought that by adapting to nonviolence, by adapting to peace, one can win the enemy. But he tried it, and he proved it in his lifetime. And even today, I think if we go back and check, if you want to win somebody, you have to follow that route. By strength, by nothing else will able to help you. So for those of you who will be doing 20, 30, 40, 50 years now that we will be retiring because we have been given lifetime award, we don't need to do anymore. So please think in those lines. Think of something which people haven't thought of. And I started the work with Professor Mehrbaan Singh here. So special thanks to him and a long list of people. Nidhi is here in the audience, Dr. Chaudhary and Ashok, Vinod, and a big group in Odisha. And on the right-hand side, you see all my colleagues who have come to India multiple times and have helped. So please see what everyone else has seen, but you have to think differently. Thank you so much.
So thank you so much. I think it was very wonderful, enlightening talk, starting from science and linking to Gandhiji, and using probiotics as the targets or the tools to create peace in our gut. So the floor is open for questions, but because of lack of time, we will just have 1 or 2 key questions, and then we can have discussion at tea time.
Yeah, I will be around for the entire two days, so I would love to.
Yeah. So then, is there any question? Yes?
Yeah, I can hear you. No, that is, we don't know. That's a pretty tough task. We don't know how to go about it. So that's why I was telling it has to be available for the right price to everybody. How to commercialize it? Should it follow a drug route? Should it follow a supplement route? Should it follow yogurt route? We don't know yet. We are all very, and I will be taking advice from all of you as to what is a doable thing in India, and which may be different from US. And the work was done in India doesn't mean that it is applicable only for India. The same thing will work in other settings, I hope. We may have to do more studies, but in that population it may work. So what approach we will take, we haven't, we are thinking, deliberating, we don't know yet. Yes, that's yes. Lactobacillus, that we did even before launching. We were unable to, we could not do that in our main trial because you can imagine in the villages and everywhere. However, we did it. That was our basic premise. I didn't show you the data before jumping into a large, huge trial like this, and I was lucky that I got a R01 for this. But we were planning to do it in the first U01 grant, which was part of surveillance and trial, which we couldn't. But we did 2 hospital-based trial. And that is where in the first one there were 33 babies, and it was a 2-to-1 allocation, like 10, 11 babies in the control, 20 babies in the treatment arm. And we looked at the stool for 6 months. And the colonization after 1 week of administration was 100% for first 2 months of life. And this was by culture and by API. And we had our own API code for this particular strain that we were feeding, but we didn't go for any genetic analysis. And then it remained colonized quite a bit for up to 4 months, but then it dropped down to almost 0 by 6th month. Absolutely.
Yes,
Absolutely.
yes.
Yeah. Right. Yeah. Well, for these studies will be much more easier now because in fact the first thing we want to do for this particular strain is sequence the whole genome sequencing. No, we haven't done it, and after that it will be easy. We should be able to find some specific loci and then go, and it will be much easier even to, instead of looking at culturing and doing API, we can just do the probe and see which are present or not present.
So, can we have the other question because we have time? Yes, quickly.
Yeah. Yeah, that's a wonderful question. Yes, answer is yes. And when you say healthy infants, this is a preventative study, so you have to do it in healthy infants. But we did not include really premature babies or real low birth weight babies. So they were up to only 2,000 and 35 weekers, which are, in my opinion, they are more or less normal. At the same time, those are the infants also breastfed. Those are the infants still get sepsis quite a bit. So now the next step will be to go back to the smaller low birth weight and smaller babies who have bigger incidence of sepsis. The chances of getting sepsis and dying is higher. So it may work beautifully, even better results than what we saw, or it may not work because of their gut maturation, their flora, their everything else that happens. So that remains to be seen, but we can do it easily, and that's what we want to do. Thank you.
So thank you so much.
Right. Well, enterocolite. It's the junction of the small intestine and the large intestine. That's where the biggest problem is, but it can happen anywhere in the GI tract, but colon, yes. The answer is from my standpoint, the answer is a big no, because bifido. If you look at bifido, why they are there, why they are present in breast milk, you have to ask the question in a much deeper fashion. Some studies show that bifido is there in the beginning. We have shown, and there are many studies, including some done here by Dr. Chaudhary, that bifido are not present. In the first few weeks, you don't see bifido because they are strictly anaerobes, and the redox potential is not amenable for those anaerobes to grow. So first you find E. coli, first you have enterics, then slowly you have microaerophilics, then finally you get anaerobics. So if you're thinking about a disease which happens in the first month of life or 3 weeks of life, then bifido don't do it. They're not there. And when we did our 280 strains we screened about 30, 40 bifido, because that was also our choice, thinking that, okay, let's see how many bifido will work. Even in plantarum, we selected this particular one out of 22, 23 plantarum strains. So they're uniquely different. We still don't know why. And I didn't know the term plantarum. Then we said, why should plantarum? Now there are more studies. People are showing from Spain the plantarum is present in meconium, and we can discuss about that. We have also done studies in preterm gastric aspirates. We find plantarum. So which organism is doing what is the key. So you cannot stamp one bifido or lacto or Clostridia or something like that.
Yeah, so we will conclude the session. I will like to thank Dr. Panigrahi for a wonderful lecture, and also for giving very satisfactory answers to very common questions which always come in our mind. So we will now depart for tea.
Thank you.
Thank you, sir. We request Professor Rama Chaudhary to kindly hand over the memento to Professor Pinaki Panigrahi. Thank you, ma'am.
We invite you all for the high tea, and we will reassemble at 11:15.
I should start? Yeah, I think you can go ahead and get started. Hi. It's a little loud. You hear me okay? In the back? Thank you for the introduction. I'm really excited to be here. I've had a few good days with my wife. I really have enjoyed your country. I appreciate the invite, appreciate the committee inviting me, Dr. Batash and Dr. Sanders. I'm really happy to be here to start this lecture, especially after Panika's lecture. I've started all my lectures since his clinical trial has come out with a few slides about his trial, because I think that is such a game-changing trial. That I start all my lecture at that. I will say, though, that as much as I love the trial, the video that introduced him said that researchers were surprised by the results. And I, for one, was not surprised by the results. And I think if you follow me during this lecture, you also will see that it's not really surprising, the results of what happened, if you understand where probiotic literature has gone. These are my conflicts. I won't be speaking about any of those today. So I'm going to really skip around a lot, and I think that's the only way to properly really do this lecture. And I'm happy to share my slides with people. I'm going to go from topic after topic, really to give an overview, and that's what I was asked to do. When I started this in 2005, probiotics were clearly alternative. My first grant was from the Alternative Center at the NIH. My most recent grant is from the Children's Center at the NIH. Almost no one now goes to the Alternative Center for probiotic research. They go to the Cancer Society, the Heart and Liver, again, the Children's, lots of other places. And that's because the field really has advanced. When I started, I was much more skeptical. I like to do different kinds of clinical trials, not just probiotics, and I really wanted to see if there's anything there. And there's no question now that the data are there. What I think happens, unfortunately, in the probiotic research is that people don't really have realistic expectations. And part of that, and again, this is my bias as a physician, is because physicians weren't doing a lot of the research and they were expecting large outcomes. In fact, again, I don't want to pick on Pinaki because I think it's a game-changing study. But my number one complaint about the study is that they wanted to see a 20% difference. If you go next door to where the neurosurgeons are doing their conference, they see a 5% difference. That's a New England Journal of Medicine. They get super excited. And the only reason Pinaki had to do that is because of money with probiotic funding. But a 20% difference in sepsis is unbelievable. Unbelievable. A 5% difference is unbelievable. Just when you go home to pick up the New England Journal or JAMA and look at a cardiovascular study or a neurological study, they're looking at 5% tops differences, and they call that a successful drug. And in probiotics, we have to look at 20, 30, and I'm going to show you numbers today to discuss that, and I'm going to show you traditional treatments as a comparison. And then I was going to show you some additional places to get information, but there's no Wi-Fi here, so I'll just show you the websites, and you can look at them yourself. When I give these comparisons, I think that they're apples to apples. Sometimes they're different brands of apples to different brands of apples. They're not exact. I can't always give an exact what we do in traditional medicine for neck, what we do in probiotics for neck, what we do in traditional for antibiotic-associated diarrhea versus probiotics. Mainly, I can't do that because a lot of times in traditional, we don't even have any options for things like antibiotic-associated diarrhea or colic. But I think these are reasonable comparisons. I'm happy to discuss them after the lecture or throughout the next 2 days. But it's something to think about, that they're not exact comparisons. So I started again, like I said, in 2005. This is prebiotics, this is probiotics, and you just see it's gone way, way up. And that doesn't mean that it's all robust evidence, but this does show that most likely, if it wouldn't keep going up like this, I used to show a slide where I compared it to omega-3s and a few other alternative things in 2005, and those haven't gone up. They stayed stable, mainly because they have a lot of negative trials. If you want to look at multivitamins, besides vitamin D, they're pretty stable, mainly because they're mostly negative trials. Again, I think Benaki's study was a tipping point, but I think there was a tipping point about 9 months before that came out. There was 3 articles in JAMA. And like I said, in 2005, you wouldn't see 3 articles in JAMA. The first showed a 150% increase in probiotic use in the US in the last 10 years. Again, that doesn't mean the evidence is better, people are using it, but that often goes with evidence. The second was an editorial, and what they wrote is, not all supplements, of course, lack evidence of efficacy. Many supplements, including vitamins, minerals, and probiotics, are important components of modern healthcare. And you would not have seen that in JAMA 5 to 10 years ago. You would have seen the headlines, I think it was Pinaki or one of the earlier speakers who said, is this fraud or is this a real thing with probiotics? And that's what you would have seen, and now you see this. And then the last article was a review where they recommended probiotics for antibiotic-associated diarrhea. So you had 3 articles in one edition of JAMA about, I thought I had the date, yeah, last October. This is the other thing you often see. You'll see these things, you know, what we recommend for tips to improve your digestive health. And you'll say fiber, which I'll show you is not true. But water, oily fish, and probiotics. And it's just stated there, you know, like it's a fact. Like there's no debate that that's part of what you need to do. I don't know how many are MDs here, but and the number one stat we use now is a thing called number needed to treat. And again, in Benaki's, I think it was 27 infants had to be treated to prevent sepsis, which is, again, unbelievable. It means how many people need to be treated have a benefit. I'm going to give you a few examples here. So vitamin D, if you go to an old age home, everyone's on vitamin D to prevent hip fractures because you need to treat 36 to prevent 1. Antibiotics for sinusitis is 18, so I don't know how often you treat it in your country, but in our country, people come in all the time for I would call it colds / sinusitis, and they get antibiotics. The number needed to treat is 18, but the number needed to harm, how many people actually get harmed from antibiotics, is 8. So more people are getting harmed than getting benefit. Now, the harms aren't as bad maybe as some things, but often it's bad diarrhea, and it can be C. diff diarrhea, which is obviously very bad. Aspirin during acute MI, so when I see patients, if we have someone with acute chest pain, even before we call 911, we get them to chew on the aspirin. We run to do it. We need to do 42 people to benefit 1. Oh, jumping ahead. You need 2,000. You know people take it daily to prevent non-fatal MI. You need 2,000 people need to take it. This is one of the lower ones. So if you have someone with COPD exacerbation, to give them antibiotics, it's actually 8 to prevent death. And then probiotics for antibiotic-associated diarrhea is 9. I'm going to show you that data. And for necrotizing enterocolitis is 41. Again, you can just see sort of where it falls in these categories. When I was finishing my slides a few weeks ago, I pulled just the JAMA from that week, just to give you an example. There were 3 original articles. One was a modeling study, and one was a retrospective cohort. So I reviewed the 1 RCT. Here's the 1 RCT. It was about dementia, Alzheimer's disease, to assess whether adalaperidine, is effective for symptomatic treatment to mild to moderate Alzheimer's disease. And I don't know, again, I apologize in your country, but in our country, they've been telling us it's the decade of the brain. It's the decade of the brain. The advances have been unbelievable. They did 3 randomized clinical trials that included a little over 2,500 patients with mild to moderate AD. They did it 3 different doses or placebo. In patients with mild to moderate AD, the use of adalaperidine compared with placebo did not improve cognition over 24 weeks of treatment. I can't even tell you how many millions these studies cost. These studies cost lots of money, about $50,000 a patient usually, because of the scans they have to do and the follow-ups they need to do. Anyone in family practice in the US is not surprised by this, and that's because this is the Cochrane review. I'm going to use most of my data I'm going to show you is Cochrane. I think that's the highest level of evidence, but I'll show you some other stuff. I'll tell you if it's not Cochrane. There's very little evidence that cholinesterase inhibitors affect progression of dementia or cognitive test scores in mild to cognitive impairment. The American Family Physician, that's one of the second or third most read journals in the world, says many experts in dementia care use cholinesterase inhibitors to temporarily improve cognitive and functional performance in patients with mild to moderate Alzheimer's disease. But evidence of clinically meaningful benefit is lacking. And the most shocking, over the past 15 years, more than 400 clinical trials for therapeutics for Alzheimer's disease have been registered, with a failure rate of nearly 100%. It's actually 96.4% trials. So again, next door they're doing neurosurgery, but if they had a conference about neurology, about Alzheimer's disease, that would be the slide I'd show and the conference would be over. There'd be nothing to talk about. They have no positive, they have 96.4% of trials are negative in the decade of the brain. Again, one of the, I think, committee members said before we start using these, we need to make sure they're safe, and I agree. So before I talk about the data, this is the largest safety study. And I will say that people doing probiotic literature, again, I'm going to keep talking about Pinaki, he did an excellent job of collecting adverse events, but a lot of times people don't do that, and you need to do that, because a lot of the data is lacking because of the original studies where people didn't collect data because they said, how could you have an adverse event? But you definitely can have adverse events, as you know. But this was 622 studies reviewed. RCT showed no statistically significant increased relative risk of the overall number of experienced adverse events. There are case studies. They're very important case studies. There was a case study about 3 years ago where an infant in New England died from sepsis that they got from a probiotic, or they got from a contaminant from the probiotic. It's not really clear. But the take-home message from this large study was the available evidence in RCTs does not indicate an increased risk. However, there are rare adverse events, and I would say it's really important for people doing research in the field to collect all adverse events. So we collect everything, and in fact, in most of our trials, the placebo group has more adverse events, which is always nice to see, but we do collect all of it. So this is already talked about a little bit, but I want to show you the actual data. There's 20 studies, 5,500 infants. The relative risk of decreasing NEC was 0.43, number needed to treat of 30. To actually decrease, that was to decrease NEC, to decrease death is 41. There are case reports of systemic infections, we talked about that. But I'm going to show you a few other Cochrane reviews, and for those, again, in the medical field, the number one complaint about Cochrane is that they're too strict and too rigid, and they never really find things that they recommend. They say there's more evidence needed, always more evidence needed. But this is what they said about NEC. Our updated review of available evidence strongly supports a change in practice. Head-to-head comparative studies are required to assess the most effective preparations, timing, and length of therapy to be utilized. Again, when you go back and you look at Cochrane reviews or have your students pull these, look at their final conclusion and see how often that says that. I've written Cochrane reviews. They're very strict about what you can say and the data. And this is, to me, as strong as it gets. And to me, it's really a shame that more and more hospitals are not either studying probiotics in the NICU are just using them and finding out what happens with the data. It's almost inexplainable. We can talk about it. I don't totally understand it. The only rationale they can have is they could ask me what product to pick, is the only reasonable argument they could make, but that's not really a reasonable argument with the data this strong. This is what Cochrane says about mammogram. If we assume that screening reduces breast cancer mortality by 15%, and that overdiagnosis and overtreatment's at 30, it means that for every 2,000 women invited for screening throughout 10 years, one would avoid dying of breast cancer, and 10 healthy women who would not have been diagnosed if they had not been screened will be treated unnecessarily. Furthermore, more than 200 women will experience important psychological distress, including anxiety and uncertainty, for years of false positive findings. Again, I'm not against mammograms and all. And it's a lot of this talk, I should have said at the beginning, might make it sound like I'm against allopathic medicine. I'm not. I'm a physician. I practice. I'll show you some flu data. My kids got the flu. I get the flu shot. But in the US, there are vans traveling around getting people to have mammograms. But they don't understand the data. And again, I'm not opposed to it. I understand people should get mammograms. It's the only way right now we have, unfortunately, to find early breast cancer. But this is the data. And there's no debate about the data, really. This is the data. When I was in medical school, we were told to use beta blockers. This is what Cochrane says about beta blockers. These RCTs were conducted between the 1970s and 2000s. Most of them had a high risk of bias resulting from limitation in study design, conduct, and data analysis. Current evidence suggests initiating treatment of hypertension with beta blocker leads to modest cardiovascular reductions and little or no effects on mortality. These beta blocker effects are inferior to those of other antihypertensive drugs. So again, I don't know how you're practicing in this country, if that's your first line or second line, but really it should be your fourth line. And the data are there. But it's taken many, many years for that teaching to get across. And again, for NEC, our updated review of available evidence strongly supports a change in practice. Ulcerative colitis. I think it's really interesting that when it comes to Crohn's disease, there's never been a positive probiotic study, but ulcerative is, which, you know, in medicine, we treat them very similarly. But clearly there's something different going on in the microbiome with these kids that are treated differently. But this is one product. So one of the arguments people make is, okay, Dr. Marianson, you showed me the data, but I don't really know what product to use. But this is one product. It's called VSL3, and I've never worked for them. I'm not here to shell for them. But they have 3 low-risk of bias studies with 319 patients. The remission rate was 44.6% versus 25.1%. You work your way down with the relative risk, the absolute risk. The number needed to treat is 4. So I have 4 boys. I have one with ulcerative colitis. He is taking this from day of diagnosis on. And I'm not a GI doctor, so I don't know if I can say what's malpractice, but I think it's close not to at least tell your patients who have ulcerative colitis about VSL3. The data are so clear. The number needed to treat is so low. Again, the main problem, and someone brought it up also before, is it's an expensive treatment in the US. I don't know what it is here, but in the US, it is an expensive treatment. And they say no serious AEs. And again, I think they do need to report more AEs and be more balanced about that. Oh, influenza vaccine. And I got new data, actually. I wasn't able to put it in because I already had my slides, but I had new data that was sent out this morning by the CDC. But this is as robust a data set as you're ever going to see. You're never going to see this kind of robust data set. 90 reports, 116 data sets, 69 clinical trials, 70,000 people, cohorts, 8 million, 20 case controls. So there's really no debate about this data. The overall effectiveness of influenza-like illness, number needed to treat is 40. To actually prevent the flu, and this is a good one, it's a good one, is 71. Okay? If I don't get the influenza vaccine, I get thrown off my faculty. I was once on a sabbatical. I didn't come back until after Christmas, and I was literally taken off the faculty until I could prove to them that I had gotten the flu vaccine. That's how important they think it is. And again, it is important because the flu is such a killer, and it's a relatively easy shot. It's in the US very, very cheap, so it makes sense to get it. But the way they talk about it, you would think the number needed to treat is 1. Get your flu shot and you're going to survive, and it's 71. This is data, again, like I said, this was data a month ago, but now it's actually new data. But the data a month ago was the predominant virus this year, the H3N2, effectiveness was 43%. The data I got this morning is it's 25%. Okay, so it's 25% effective against the number 1 strain. And usually we find out what's effective from what Australia is. In Australia, it was 10% this year. So it's 10%. And again, I got it, my 4 boys got it, my wife got it. I will get the flu shot probably every year. But I'm not going to be stressed if I get it in November 15th rather than, October 15th. It's not number needed to treat 1. This is even more bothersome, and I don't know, again, if you use this medicine here, but in the US, we use this medicine like candy. It's called Tamiflu, and the doctors love it because patients come in, we don't have to give them an antibiotic, which we're trying to decrease. We can give them this where we don't have to worry about resistance. Tamiflu, again, a lot of studies, 170 studies. It reduces your illness by 16.8 hours. That's the data. The CDC knows the data. They say that on their website. They don't argue that. They tell you to give people it, but it reduces it from 7 days of illness to 6.3. Again, there's no debate about the data. The debate is it worth it because it has such a low number needed to harm? You talk to patients, this is the number you are in the studies, but lots of people get neurological symptoms, crazy dreams, or really bad stomach aches from this medicine. But we use it all the time. Patients line up to get Tamiflu. We call it Tamiflu or Ostelmaro. I want you to remember that 16.8 hours, because the number one complaint when I first started doing probiotic research, I'd go to conference and they say, well, we have this thing, but it just decreases diarrhea by 25 hours. That doesn't sound that significant. And again, I think they say that because they don't understand what we expect with data. 25 hours throughout the whole society is a lot. Mom gets back to work quicker, kid gets back to school quicker, it's spread less, lots of things with that. And this 16.8 is a multi-billion-dollar drug for 16.8 hours. All right, Cochrane review of acute respiratory infections. Now I'm back into probiotics. 12 trials, 3,700 people. 47% reduction in persons experiencing acute respiratory tract infection. My talk this afternoon is about a study Dr. Sanders and I did, and I'll talk more about this study later. The mean episode duration was reduced by 1.9 days. That's a lot, 1.9 days. Also reduced antibiotic use, which again is really important. I'll talk about this afternoon, and cold-related school absences. The problem with this study, if you ask me at the end, is, okay, Dr. Anderson, what drug should we use? What probiotics should we use? That's a little more difficult. So that's where more future research needs to be done. So these are meta-analysis. The data is really robust and promising, but we don't know that yet. Some of these things I'm going to show you, VSL-3 for ulcerative colitis, colic, I think some things for neck are clear what you should use, even some diarrhea ones, but this one is not so clear. All right, lowering blood pressure, 147 trials, 464 people. Decreasing blood pressure, even by a little bit, 10 and 5, systolic 10, diastolic 5, has a 22% reduction in coronary artery disease and a 41% reduction in stroke. This is a super famous study. It's called the ALL-HOT. This is when we started using, this is a diuretic, calcium channel blocker, ACE inhibitor, systolic, diastolic. So the one drug decreases it. Again, if your patients are like my patients, they usually need 2 to 3 drugs to decrease it, but this is how much you decrease it to 1. This is how much the Cochrane found with diet. 34 trials, average of 4.2 or 2.6, systolic, diastolic. The DASH study is the most famous diet study out of Hopkins, and they found 5.5 and 3, 6.7 and 3.5. So just diet alone, you'll see people would start with the high blood pressure. We talked about diet alone is what we should start. That doesn't work, then we go to the diuretic, and then either the ACE or the calcium. I hope you can see this. I don't know how well you see it. Take my word for it. This is probiotic review of hypertension. And I was shocked at this data. When I was preparing for this talk, I had never seen this actually. I was trying to add a few things. I know a lot about the diarrhea data. That's what I study. The colic data, the neck data. I've written about that, so I know that. But I did not know this. And if you're going to ask me the mechanism, I'm not going to answer because I don't know the mechanism. Okay. But this again up here, I think my pointer's done. But okay, on the top is systolic, and on the bottom is diastolic. Oh, you see it, sorry. These are systolic numbers, diastolic numbers. So the average of all these probiotics is 3.5 cyst and 2.3 diastolic. Some of them, as you see, really have lowered it quite a lot. 11, that's like almost as much as the diuretic, which is really impressive, 9.7. So I think like on our Dr. Bernanke show, we probably have to find the right one. But there's probably is something here. And again, this isn't anything I study. I'm probably not going to study it. It's not my interest. But there probably is something here for people who are interested in blood pressure, either cardiologists, nephrologists, primary care doctors, finding the right probiotic that could do something is really interesting. This is a website. There's one in Canada and one in the US. You should maybe get someone to do one for India. They list all the products, and they list the actual product name, the strain name, and the reference for the study, so you can look up the studies. I think they're a little too lenient with their grading, but I think it's a really nice way to say, okay, is there any studies? This is how I found on, say, hypertension or colic, and you can look it up, and you can look the study up yourself or have one of your students. All right, let's get to diarrhea. Again, someone already sort of showed this. Third leading cause of childhood mortality in India. Per UNICEF, diarrhea is a leading killer of children, accounting for 8% of all deaths under age 5. Translates to 1,200 each day, or 45,000 a year, which is just an unbelievable number. So the Cochrane review had 63 randomized trials. 63 randomized trials. That's unbelievable, that many probiotic trials. 8,000 participants. 56 of the trials, as you can see, almost all are in infants and young children. No AEs reported, which I think is interesting, but I also think that means they probably weren't doing the best studies if they had no AEs reported. There should be some AEs reported. The average improvement was 24.76. So again, you could get up here and say, that's only 24.76, or you could say, that's unbelievable, that's better than Tamiflu, that's as good as, lots of other medicines. For strep throat, besides the spread of rheumatic fever, the other thing is it gets the kid better by a day. Otitis media, it's about a day. So all these respiratory things about a day. Probiotics in general, over a day. We definitely need more data on morbidity and mortality. A lot of these studies are done in places like the US and Europe where there's not going to be much mortality, thankfully, but we do need to keep track on that. Their conclusion was, used alongside rehydration therapy, probiotics appear to be safe and have a clear beneficial effect in shortening the duration and reducing stool frequency. I pulled two studies out just to show you two local studies. This was done in Tada, Maine Hospital. I'm not going to try to pronounce. It was the Saccharomyces or placebo given to kids with acute watery diarrhea. So a lot of these studies are prevention. The two I'm going to show you I think are really interesting because the kids were actually sick. They had rotavirus. 30 per group. They were given 250 milligrams per day. The average age was 24 months, 58% male. So they're pretty young. 29-hour improvement. That's really unbelievable. To have a 30-person study show a statistical significance is really impressive. And again, this is prevention, not treatment. Second one was an open label study in Meerut, India. I apologize if I said that wrong. 200 children, mean age 19 months, 54% male. They had acute diarrhea and they received LGG, that's the most studied probiotic in the world, or placebo for 5 days, just 5 days. 24% were positive for rotavirus. Regardless if they had rotavirus or not, they had about a 19-hour improvement. So really impressive improvement with diarrhea from the probiotic. And again, the big complaint about the overall meta-analysis is I don't know which one to pick. But these are clear. That was the SB and the other one was the LGG. It was very clear what they did. I study antibiotic-associated diarrhea. I study it with a probiotic called BB12. But this is the Cochrane review. There's 23 studies, 11 of which use a single strain. The incidence of AAD was reduced in the probiotic group to 8%, in the control group 19%. When you work your way down, it's a 58% reduction. Absolute risk 11, number needed to treat of 9. It's really a low number. It's gotten to the point where if you're going to put someone on antibiotic, you at least need to tell them about antibiotics. I'm not sure why you wouldn't tell them about it. If they say, I've never had a problem in the past, maybe you could do it, but there's really almost no reason not to tell them. The number need to treat is so low. Even more important, because it's unfortunate to get diarrhea from antibiotics, it often in the US results in them coming back to the doctor and going on a second antibiotic, a stronger antibiotic, more broad spectrum, which is a problem. But this maybe is even worse, the C. diff, obviously. So there's 31 studies, 27 rated either high or unclear bias. Probiotic group was 1.5, the control group 4%. And again, this is where small numbers mean a lot because C. diff is so important. Risk reduction 62, number needed to treat of 40. Not surprisingly, when they do the post hoc analysis, it really matters probably what antibiotic you're using. If you're using something like Augmentin, which I don't know if you call it amoxiclavinate probably here, or something like that, you're going to probably almost for sure going to see some kind of loose stools or diarrhea from that. Not for sure, but that's up to 25-30% of people. Using some other ones, if it's really low risk, maybe you don't need a probiotic, and probably wouldn't be at a benefit if it's such a low number to start with. You definitely, I cannot see this, apologize, but in the US, a survey showed that 87% of formularies have a probiotic. Unfortunately, what you can't see is that the number one is LGG, but the number two is one, Benaki already talked about, it's called Lactinex. And this gets to really, I think what happened when I started this research, I didn't believe that doctors are getting to the point now, from the JAM article and from the nice, obviously a great study in India where it was all over news, that they understand that probiotics have a use. But they don't really yet get often the difference of probiotic A versus probiotic B. So my hospital still uses this one. There is no data that works. In fact, there's good data that doesn't work, that as soon as it hits the GI tract, it dies. I have presented this to my formulary group, and they still use it, and why do you think they use it? Because it's cheap. That's why they use it. There's a simple reason, and they're straightforward about it. It's cheap. And they even have told me it doesn't seem to work. And I'm like, I told you it doesn't work. Why do you keep using it? So one day they'll stop using it. But the data in most hospitals are carrying this in the US now. This is it's not a Cochrane review, but it's a high-level review. It's called the pharmacist letter, and they're very, very strict in their review, their comments. And they say treating 12. Remember, I got the number needed treated 9. It just really matters what studies you put into it. With the probiotic prevents antibiotic-associated diarrhea, and they have a lower C. diff of 29. And they say probiotics may reduce the duration of acute diarrhea in children by about 1 day, about the same we said. And again, that 1 day is important. It really is important. Do you guys use fecal transplant in this country? So for C. diff? So we use it. It's at every hospital in the US pretty much. Every community hospital, the GI doctors jumped on it. They went crazy. And in fact, it's at the point now, the last conference I went to about FMT about 6 months ago, where the leaders in the field said, for C. diff, it's not ethical to do a study anymore. And I'm going to show you the data that they said it's not ethical. For ulcerative colitis, for obesity, for diabetes, there's going to be studies for sure. But they say for C. diff, it's not ethical. And this is why they say that. They have 7,500 original articles. Those aren't RCTs. Those are case studies. You know, I did it. It worked in my hospital. You did it. You worked in your hospital, okay? There are 3 double-blind RCTs involving 219 total patients, plus 1 negative. 3. 1 was done with fresh versus frozen stools. 1 was via NG tube, and 1 was for colonoscopy. So again, I don't expect you to remember everything I said. I'm flying through. But if you remember the other studies, there is, I think, 4,000 with antibiotic-associated diarrhea. With necrotizing enterocolitis, there's a couple thousand. There's that. And the number one complaints people make is, well, the problem with the neck is every hospital did it differently, or they used a different strain. Well, look, they all do it differently. And they're clearly using different strains, right? There's no question about that. But they're done. With C. diff, it is done. You cannot ethically do that study in the USA. There's not an IRB in America that will let you do that study based on this. And I'm really excited by by FMT. I think it's really interesting studies. But the data is not that robust. And I just want to take a quick side. I'm going to talk about colonization in a second. The really interesting thing is it does seem like in ulcerative colitis it works acutely. But as soon as you stop giving it, it stops. So it's a really interesting thing. We'll talk about colonization. Maybe I have one more slide about it. But it's probably doing something acutely that's helping these kids get out of their flares. But as soon as you stop, the kids go back to having ulcerative colitis. This is another website I want to show. I am representing ISAP here. I appreciate you guys inviting us. We have different videos and different take-homes, little pamphlets you can use to educate yourself, but more importantly, probably to educate your colleagues who aren't here, who aren't going to probiotic conferences, and your patients. We have both patients and researchers. All right, a few more. Again, I know I'm jumping around, but I think that's the only way to really give you a feel for what's out there. Colic. There's 4 double-blind RCTs, all again using the exact same strain, so there's no debate here about the strain. It decreased crying time by 25.4 minutes. In breastfed, 28% success versus 9%. This is really breastfed. Number needed to treat is 4. No AEs, and these are more recent studies. That's a rhetorical question. We have no other option for colic. So in primary care, pediatrics, whatever, family medicine, there's nothing else to use. There's placebo, which we sometimes do, or we sometimes even do Zantac, which probably causes problems. Maybe long-term problems. We don't know. You know, if it's decreasing the acid there for colic. But this works. Now you could say it's only 25 minutes, and that's reasonable. And I'm not a mother at home with the crying baby. The people who run these studies say that's a significant time. That they've talked to the mothers, they've done qualitative research, and that matters. Again, it's not my field of research. I don't know. But they set the studies up properly. They randomized, and they did this meta-analysis. And I would say it's the best kind of meta-analysis because they actually got the individual patient data. They didn't just grab, they got the individual patient data for all of them. It's the highest level of evidence. Abdominal pain. Recurrent abdominal pain is a common problem. About 4 to 25% of school-age children. Again, most of this data, I apologize, is US data. 19 RCTs comparing different dietary interventions. Children treated with probiotics were more likely to experience improvement, 63%, in pain at 0 to 3 months than those given placebo. The number needed to treat is 8. But you know what we generally do when people come in with abdominal pain? We tell them to increase their fiber and water intake. What they found is there's no convincing evidence that fiber-based interventions improve pain in children with recurrent abdominal pain. But we're still doing this. hopefully the beta blockers, a lot of people aren't doing anymore because it's finally trickled in. But fiber we're still doing on a regular basis in nursing homes and in pediatrics. If someone comes in with abdominal pain or IBS, we go to fiber. I want to see a positive study. I've mainly been showing you Cochrane reviews, but there's other groups who have reviewed this who also recommend it. I didn't talk at all because I can't get it all in. I think it just gets too confusing. But there are some really interesting studies about allergies. And there's a recommendation from the World Allergy Organization for probiotics for allergy prevention in pregnant and breastfeeding mothers at high risk of having an allergic child and in infants at high risk of developing allergic disease. So we definitely have a lot of that in the US. It was talked about. We have lots and lots of kids with severe peanut allergies. It's a pretty high percent. Kids with other kind of allergies, things like eczema, where it probably is worth it if mom knows it's in the family to start the probiotic when she's pregnant and probably to continue it with the kid. Oh, did I miss a study? Oh, I'm going to go with this one first. Colonization. So we had a talk before I was invited. We had a few phone conversations, which we talked about, what I should talk about, and what kind of probiotics people are using in India. And it was brought up a few times that colonization is really, really important. And I'm going to disagree with that, so we'll talk. This is the definition of probiotic. Live microorganisms that administer an adequate amount confer a health benefit in the host. There's no mention of colonization there. No mention of colonization. Do drugs colonize? And I asked that question, but drugs generally don't colonize. We have strong biotherapeutics that we use for ulcerative colitis, medicines like Remicade, that we know if the kid's a week late from their medicine, that they're going to go into exacerbations. It doesn't colonize. It doesn't change the environment. Now, I think the question is, more importantly, does it change the microbiome for a short term or not a short term? So I know the probiotic I study, after about 2 weeks in the general person and the latest person in 4 weeks, we can find the probiotic. Some probiotics stay a little shorter, a little longer. And there is some argument. There was a study out about 2 years ago where they showed one that seems to colonize and stay. But I don't really think that's the issue. And if they do colonize and they change the microbiome for good, that's a potential safety issue. And it's an issue that probably in the US, the FDA is going to be very, very interested in. If I'm going to give a kid a probiotic and I'm going to say, I'm confident this is going to change their microbiome for good, not just for the time they're taking it, that's the thing that the FDA is going to be very, very interested in studying. So I know I specifically left time for questions, but these are the ones I always get asked, so I thought I'd just throw them up. Is a higher dose and a greater number of strains better? And I would say not necessarily. If you have a good plantarum dose that you studied and you have a hypothesis and you have a reason for it, then that might be all you need. If VSL3 has, I think 8 strains, maybe that's fine for ulcerative colitis. Maybe it's not needed for other things. Is it better to take probiotics as supplements or foods? I'm a little biased because my research is in foods because I think compliance is higher, but the research really doesn't support that. It's really whatever it's studied in is the way it should be taken. Are they beneficial for healthy people? So I'm going to talk a little bit about that in my short talk later. And the question I always get asked is, so Dr. Manstein, should everyone take a probiotic? That's the question, And it's not so straightforward. I will say that preparing for this talk, the hypertension, the blood pressure study was impressive to me. I don't have high blood pressure, but I probably could benefit from a 5 millimeter decrease. That'd be reasonable for no reason. The acute respiratory infection disease, decreasing the chance of antibiotic, that is promising that maybe more people should take it regularly. I don't have a specific answer for that. We'll talk a little bit more about this afternoon, but I think it's potentially possible. Are refrigerated products better than non-refrigerated? That's really important, obviously, for your country, for the countryside, and it really just matters. We have products in the U.S. that last shelf-stable for 18, 24 months, no problem. We have it in infant formula, 18 to 24 months, so it doesn't matter. A lot of the people in the U.S., the health gurus will say, well, it has to be refrigerated. If it's not refrigerated, it's not going to work, and that's just simply not true. Take-home points. The data are there, and again, I think even my funding sources show that the data are there. Initially, it was all about going to the alternative group at the NIH, and now no one really thinks about it as alternative. It's every funding agency at the NIH will have probiotic studies going on. But you have to have realistic expectations. I'm really impressed that they show such a decrease of 20%, but I would have been really impressed with a 5% decrease in sepsis. 5% decrease in sepsis throughout your whole country and through other countries like this would have been unbelievable. Unbelievable. You need to be realistic. So we're still learning a lot. Again, when I started in 2005, it's totally different than what it is now. And we've learned a lot. And I think as we learn more about the microbiome, things will change and we'll get a little more specific. I'm a little hesitant to say that because when I was in medical school, everything was genetics, genetics, genetics. And they said, you're going to come to the doctor, you're going to prick their skin, you're going to take a little blood, and you're going to tell them, are they better off on an ACE inhibitor versus diuretic? Should they take this antidepressant, that antidepressant? And we do that for some kind of cancers, but for most things in some kind of anticoagulants, but for most things, we're still years and years away from that. But I think it is promising, but I don't want to promise that that's going to happen soon with probiotics. Small changes are important. Again, it has the cost. You need to take the cost into account. For most people, that I see in the US, that the costs are pretty minimal. Now, obviously, where Pinaki did the study, the costs are much more different. They don't have that money for that, so we need to figure out a way to make the costs. But again, for any drug, for the Tylenol I give or the aspirin, it's a plus minus, the risk versus the benefit, the cost versus the adverse events. And then finally, probiotics aren't the flu shot, but the flu shot's not really the flu shot, or it's not the shot that you were sold on. So thank you very much for your time.
Thank you very much, Dr. Merenstein. I really appreciated your evidence-based approach to looking at the data and comparing medical treatments with probiotic treatments and showing that oftentimes our expectations are so unrealistic for what effect sizes we expect to have for probiotics, and oftentimes in medicine we just accept treatments that have an equivalent or even worse effect size. So I think that that's a really important point for people in the field. We have some time for questions, so can we open it up for questions from the audience?
Good afternoon, sir. My name is Harish, and my question is on the colonization part which you were just discussing. I'll give a background. I'm from the animal nutrition industry. So here we are taught that competitive exclusion is the only way probiotics work. I mean, that's the primary way. So when you say that colonization is not important, so exactly how is a probiotic effective?
So just so I can repeat, you said that competitive exclusion is the only way they work? Is that what you're saying?
Primary.
So again, so I'm a clinical trialist, and other people here are, microbiologists and biochemists, they can answer it. But I think there's probably 9 to 10 ways that probiotics work. Most of the things we're seeing probably with antibiotic-associated diarrhea is with short-chain fatty acids and probably not exclusion. I am not saying that colonization is not important, or potentially. I'm saying that it's not in the name of a probiotic, so it doesn't have to show that it does that. That drugs don't do that as a general rule. If drugs did that, there'd be a serious problem. And that, let's take, for example, LGG. So I think Pinaki and others showed that it doesn't colonize, but we have clinical data, good clinical trials that it works. Works for things like eczema, diarrhea, things like that. And to me, that's much more important than showing it colonizes or doesn't colonize.
Okay. Thank you, sir.
There's another question here. Oh, no. Any other question? I'd like to also add in terms of that colonization discussion that we actually have evidence that they don't colonize. I mean, most of the studies where you track persistence of fed probiotics show that, as you said, in 2 to 4 weeks, it's gone. Now, we could maybe parse words about what do you mean by colonization, and probiotics likely grow and can last longer than an inert biomarker as it's transiting the gut. But I think that when you use the word colonization, you typically think of a permanent colonization or at least long-term colonization, and they just don't seem to do that. Yet, as you say, you have all this evidence that they work.
Any other questions?
Here's one more comment.
Yep, comment, question.
Actually, colonization is a very, very crucial, process for optimal expression of the efficacy of the probiotics. So if they colonize, transiently, as most of the strains, they will do, or probiotic strains will do, in the colon. So then there's no problem. But if they stay longer than what is required, then how it is going to impact the, the functionality of those strains?
So I agree they'd have to transiently colonize. They couldn't just go straight through because that would obviously not do anything. But I'm not sure the question then after that.
No, colonization, if they don't colonize, what does it mean, if they don't colonize?
Well, the way I was interpreting it, I think the way people have been colonized before is that you take the probiotic for 4 weeks, and you take your LGG, and then 6 months later you look and you say, is LGG still there? Did it stay? Did it colonize into the
No, if we have to choose, between those strains which colonize and those which do not colonize, so which will be your option, then?
So no, I think you need to choose one that survives the gut, the acid in the gut, and one that colonizes transiently. I think the data are clear that, as Mary Ellen and Dr. Sanders said, that the mass majority of probiotics don't colonize, but have been shown, I should say all, have been shown to have a clinical impact without colonization. And clinical impact is really the gold standard, because if you colonize and don't have a clinical impact, no one cares. They shouldn't care. All we care about really is the clinical impact, and many, as I just showed, have a clinical impact without colonizing.
Yes, I remember, we had some discussion also. You said that
I remember vividly, yeah.
colonization is not required, That's what I was wondering,
I put the slide in for you.
That means, is it a negative, kind of
So
process?
colonization could be negative. I mean, I think if you're going to change things, in the U.S., the FDA is going to get very involved if you're changing things permanently. Pinaki has a point.
Yeah, if I may just wrap up what I am hearing, colonization can be used if you think that if you give 1 dose or 2 or 3 and it stays there. That is what we are probably, many of us are thinking as being colonized.
But stays there for how long?
Yeah, for how long? And the answering Dr. Battis's question is, if it stays there for 6 months, 1 year, 5 years, that's bad. I don't think I would like that to happen. FDA wouldn't like that to happen. Whereas if you feed it today, this morning, or few days, and it doesn't survive the acid and alkali, and it is not there at all, then we don't know whether it will work or not. Right. But at the same time, even if it doesn't, you don't see it, they are dead. Who knows, they're not releasing some molecules. Who knows what the real mechanism of action is, which we don't. The study that we did, we were looking at, we probably used the term colonization incorrectly. You feed one today morning, you don't see it that day. You feed once a day for 1 week or whatever period of time. During therapy, we did not culture it from stool. That's what we really meant.
Okay. I think it's a great discussion. Okay, thank you so much, Professor Merenstein. I appreciate your conversation.
I request you to be there.
And may I, before you begin, I'm sorry, I was remiss in my introduction by not saying that Dr. Merenstein is representing the International Scientific Association for Probiotics and Prebiotics today. So I'm thanking ISAP for the support to send Dan all the way from Washington, D.C. to give this lecture. And also I would like to comment that Dan is on the board of directors of ISAP. Thank you.
So thank you so much for the wonderful talk we had from Dr. Dan Merenstein. Just small quick announcement, those students who have to put the posters on the first day, please put your posters. The evaluation will be done in the lunch time, and you can stand that time along with your posters. I would now request Dr. Batish.
Thank you, sir. Now I would like to request Professor V.K. Batish to kindly hand over the memento to Professor Daniel Merenstein.
Did you what?
I didn't get you.
What? Yes, come here.
Some memento.
So I think we're done, right? Okay, yes, I'm done.
Now we begin with our next session. Now I would like to invite Professor Madan Lal Mohan. Madan Lal Mohan, he is a Joint Director Research at NDRI. He is a pioneered research in embryology, biotechnology and product, and produced world's first buffalo calf Pratham. He published over 226 publications in Indian and international journals. He is fellow of 6 science academics including the National Academy of the Science and the National Academy of the Agriculture Science. He is recipient of the many awards, including the ICAR Rafi Ahmed Kidwai Award, ICAR Hariom Award, Dr. B.P. Pal Award, and D. Sudarshan Award in the Dairy Science, and many more. He has contributed significantly to national research, education and development as chairperson and member of several committees of ICAR and DPT, etc.
I invite Professor Motilal Madan to kindly join us.
Sorry for the error for the name. Dr. Madan, please come on the dais, please, to chair the session.
Now I would like to request Professor Vineet Ahuja. He is the Professor, MD and DM, MNAMS Department of Gastroenterology. His research interest is luminal gastroenterology, inflammatory bowel disease, peptic ulcer disease, gastric esophageal reflux disease, and amoebic liver abscess. I also request the chairperson to introduce the speakers.
Should we start?
Yeah, please.
Yeah, I have the program. Okay. It's just past 12 and good afternoon to you all here. Pleasure in being here amongst you for this very important session, which is supposed to be talking about the probiotics and gut microbiome in health and disease. The two words, the health and disease, are not supposed to be the two sides of a coin, same coin. Often we say the disease condition is different from that what we call as health. But in fact, that today we are going towards to the aspects of what we say things away from disease. We are talking of health as such and various connotations of health. I remember several decades back when I was a young child, and my grandfather used to tell me about expressions which we get out of different terms and words. I think 3 or 4 of them were still relevant and were relevant to what we are here today for. He often talked about the situations that when we talk the gut feelings. What do we mean by that gut feeling? He also talked about the gut strength. He did talk about the gut tolerance. And above all, he talked about the gut capacity. I think at that time we did not have any concepts of microbiome, or we did not talk about the definitions as we have got them today. But I'm sure that it was said at that time that gut has to do something with your capacity to think. They used to say that if your gut is not doing well, you are not capacity to think. It was said that about that you should have the feelings which come out of the gut. It was said that your strength, true strength, is not in the muscles, it is in the gut. So I think that a long way we have come from there, and today we have an enunciation, we have a definition of what was being said then. And we have now this microbial configurations which bring about this ever-changing environment in our gastrointestinal tract, bringing in over into the development, that's nutrient acquisition in terms of immune modulation, in terms of brain development, and of course, in terms of the behavior. Now, all these things are being today talked about in four very important lectures. And I think that we'll be listening to them and you will get some feelings in the same fashion as have been put to a short introduction. To start with, I have Dr. Yogesh Shok, who will be speaking about the Indian human microbiome and implications on probiotics. I hope the speakers are well aware of the time limitations which are in here. And the best I can do is that once they are nearing about 2 to 3 minutes of the time allocated to them, that there will be tap on the mic. We should give them an indication so that at the end of it, we are continuing in a time frame which has been allotted to us. So may I call the first speaker, please, Dr. Yogesh.
Okay, so good afternoon to all, and it's my immense pleasure to be here and share some of our work with you. I would like to thank organizers, especially Professor Batish and Sunita Grover for giving me this opportunity. Of course, they are long-time friends, and I personally thank them for giving me this opportunity for presenting some of our work here. My group has been working on Indian microbiome for more than a decade or so, and we have studied various aspects of microbiome related to diseases. And what I am trying to do today is in 20-25 minutes or so, I'll just give you a kind of overview and highlights of the research that we have carried out so far, and also tell you about the bigger plan that we have in future. So I'm sure the crowd here is aware of that, but aware of these facts, but just to put everybody in a proper perspective, when we talk about microbiome, we talk about all those microbes reside in all parts of our body, gut being the major organ, but it is not the only organ. The microbes are present in nasal cavity, oral cavity, vagina, and most importantly, all over the skin also. So it is estimated that the estimates are different now, but at least minimum we have twice as many microbial cells in our body as human, or the other estimate is 10 times more. So the fact remains that at least microbial cells outnumber human cells twice. And if we look at the number of genes that are present contributed by microbiome, that is several fold. So as against around 23,000 genes contributed by human genome, several trillion genes are contributed by microbiome, and this we have realized for a decade or so. Research has told us that this has a profound impact on host physiology, behavior, and everything. So there have been thousands of studies now on microbiome and its effect on variety of dysbiases, including behavior, nervous tissue development, lifespan, so on and so forth. India, there are very few such studies have been done. And I mean, yeah, this fact I have already mentioned, that the microbes are present in all possible organs, including nowadays we say that microbes are present in placenta also, upper respiratory tract. So all the organs microbes are present. Coming back to India, as I said that microbiome studies in India have been very little, but it's a kind of gold mine that needs to be explored. And this was emphasized in the review which we published some 4 years back, and it says, I mean, it's all known that we have a tremendous diversity in terms of cultural practices, in terms of genetic diversity, in terms of geographical diversity. So we have something like 4,693 different population group, 2,205 major communities, 1,900 territorial units. So I mean, it all has an effect on microbiome, and it is a very important aspect to study how these things are affecting microbiome, and further added to the fact that urbanization and change of lifestyle and change of diet are again contributory factors that have brought out a dramatical change in microbiome in last decade or two. So all these things need to be studied in details, and the effect of traditional practices and traditional diet on microbiome is something which really needs to be investigated. And most important, I mean, this is again, we have ours is the 7th largest geographical area, we are 2nd largest in the population, and diet is again a factor which affects the gut microbiome dramatically, and we have tremendous dietary diversity. As we move on from east to west or north to south, there is a tremendous dietary variation, and there is ample evidence which shows that the components of the diet, the way the food is cooked, all these have effect on gut microbiome. So, I mean, this is all to emphasize the fact that why Indian microbiome is unique and why it needs to be studied in detail. So, we had taken up the studies in the last decade or so, and we have been studying all aspects of microbiome, that is microbiome in health as well as in disease. In health, we are trying to find out what is a kind of core Indian microbiome and how it differs from rest of the world. We are also looking at the mother-infant microbiota, age-related differences in the microbiome, and of course, these studies would not be complete unless we have some isolates cultured and try to understand those isolates. And I'll just try to give you a glimpse of this in my talk. And in the diseases, we have been studying celiac disease, diabetes, inflammatory bowel disease, and kidney stone. But I'll just show you some highlights on diabetes and will not talk about any other disease. So this is a kind of small study which we had taken as a model study, which was started a couple of years back, and we looked at Indian microbiome, looked at the gut microbiome at a nearby village population. So this is the overview of talk, but and as I said that these are the celiac disease I am not going to talk about, I am going to talk about only diabetes here. So I'll just briefly give the background of this particular study. So we had taken up this study in a nearby HDSS, that is Health and Demographic Surveillance System in Vadu village, which is nurtured by KEM Research Center. And the advantage of this population is we have access to entire metadata of birth, death, dietary habit, migration, marriages, everything, diseases, and that's the reason we had selected this population. And we had, for this population, we had studied entire microbiome, that is skin, oral and gut microbiome. And I'm just going to show you the highlights of the research. Details we can discuss later, but there are few things which were very obvious from this study. And first thing that we saw was, we see that in case of oral microbiome, as the age increases, the number of proteobacteria increases, and in case of in case of gut microbiome, as the age increases, the predominance of proteobacteria in the gut increases, and in case of oral microbiome, the predominance of fusobacteria increases with the age. And further, we also, when we in contrast, the bacteroides population decreases with age in this particular population. And here, I would like to emphasize the other fact is that here we had done this study in the families. So what means by a family is that it's a joint family. So all the 3-4 generations which we have studied here are staying in the same house, they are eating the same food, and primarily they are exposed to the same environment. So it's a kind of controlled situation where all other environmental factors that would affect the microbiome are constant for all the members of the family. They are genetically related also, but genetics we have not included in this study. But other environmental factors like environment, diet, water, all other factors are constant. And then the effect of age on the gut microbiome development would be more pronounced in this case. So that was the idea of taking up this study, and these are the observations from that studies. We also used this data to do global comparisons, and we selected those studies where comparable metadata was available for the individuals, and we did comparisons with data available from studies from Western countries, from American countries, so from African countries, and from USA. So here is the comparison. This is a relative distribution. This is a comparison with Australia, England, India, Netherlands, Ireland and America, and you will see that the relative distribution of different groups is different in all these countries. And if we look at it, the red color is Indian, so this forms a distinct group as compared to the other population. Same if we have a look at the African, again this is the relative distribution of different groups is different in India as compared to America, and it again forms a very distinct group. If we look at the other Asian countries, then again you can see these are the other Asian countries like China, Taiwan, Japan, Indonesia, and again you will see relative distribution of different groups is different, and again here the Indian population forms a very distinct group as compared to the other groups. And again, I am not going to present, I am not presenting that data, but we looked at in details as to which type of bacteria are responsible for contributing to these differences, and we have identified certain genera and species that contribute to these differences. In some cases there is a clear-cut presence or absence, and in some cases there are differences in relative abundance. And this part of the work has already been published, but what we have found out again is that the major contribution for this difference is high predominance of Prevotella and Megasphaera in the Indian gut as compared to other populations. So presence of high number of Prevotella and Megasphaera is a kind of characteristic feature of Indian population, and in the literature, Prevotella abundance is linked with high fiber diet. So tradition, and remember the population that was studied here was a typical rural population. So they have a traditional rural diet of Maharashtrian village. So it could be correlated with their consumption of traditional high fiber diet that could explain the abundance of Prevotella and Megasphaera in their guts. So most of the studies which we have done otherwise also, the diet was typical Indian diet, and it was not a regular westernized diet. If at all the individuals were consuming some westernized diet, that was occasional and it was not a regular practice, and that was the reason why we always got a prevalence of Prevotella and Megasphaera in our study populations. And this review was published recently, which gave a kind of global picture of microbiome, and of course India was not included in this particular figure, but we just tried to superimpose our observations in this figure, and we found that yes, I mean the relative distribution of different phyla is different in Indian population as compared to Western world, and it goes more closer to African population or Venezuelan population, though again it is not identical, but it goes a little close to them. So this is, we just superimpose the data in this particular figure. Then we had a Department of Biotechnology funded project on comparative analysis of Indian and Finnish children and mothers, and I'll just show you some highlights of that data. So again, what we found here is that the Finnish population and Indian population, they segregate very distinctly in these studies, and the abundance of certain groups, like again you will see Megasphaera and Prevotella. Megasphaera abundance is very high in Indian population, Prevotella abundance is very high in Indian population as compared to Finnish population. As against that, you will see Bloschia is higher in Finnish population and it is relatively less in Indian population. And you can also see here that the inter-individual variation in Indian population is much larger as compared to Finnish population. And so when we tried to look at the organisms that contribute to these differences, again we found that the organisms like Prevotella and Megasphaera, these are the organisms which are contribute more to the observed differences between Indian and Finnish population. And in this study we had also looked at some other factors like SNP of one particular gene, which is FUT2 gene. It is fucosyl transferase gene, and the mutation in this gene results in secretion or non-secretion of oligosaccharide in the gut lumen, and that oligosaccharide secretion of that affects the gut microbiome, because that sugar is primarily used as a source of carbon and energy by the gut microbiome, and this mutation is known to affect gut microbiome. What we found was that in both Indian as well, I mean, this is the overall relative abundance of Indian and Finnish population, and you can again see that the Prevotella is present in higher number in Indian population, and also Megasphaera is higher number in Indian population, whereas it is very insignificant in Finnish population. But Bifidobacteria are predominant in Finnish, and Blauschia is again predominant in Finnish population. And the effect of this secretor status, both, I mean, the mutation in FUT2 gene affect both Indian as well as Finnish population, but the communities that are affected by this mutation are different in Indian and Finnish population. So in Finnish population, of course, the Bifidobacteria are affected by this mutation, as against that in Indian population some other groups again like Prevotella and Megasphaera are affected by this mutation. And again, I mean, we tried to look at which are the major contributors to these observed differences, and it turns out, I mean, this is again re-emphasizes the fact that organisms like Prevotella, Megasphaera, they are the ones which are responsible for these major contributors to these observed differences. This study also had caesarean born as well as vaginal born babies, and again the observation was same, that the mode of delivery definitely affects the microbiome, but the groups that are affected in Indian and Finnish population are different. In Finnish population it is Bifidobacteria that are affected by mode of birth. The vaginal born babies have higher abundance of Bifidobacteria, and in Indian cohort the Prevotella and Megasphaera are predominant in vaginally born babies, and their number is significantly less in the babies that are born by caesarean delivery. And then finally I'll tell you a little bit about diabetes. So we had undertaken this study on looking at the microbiome changes in diabetes. So again it was a study where we had taken three different categories: the individuals which have a normal glucose tolerance, then the individuals that are newly diagnosed with diabetes, and the individuals which are diabetic for a significant period of time, more than a year. We also did a lot of blood chemistry parameters on these individuals, and what we found is again that in case of normal glucose tolerance, it is vitamin B12 that shows good association with microbiome, as against that newly diagnosed diabetic individuals, some amino acid like isoleucine, valine, tyrosine, and also HbA1c, they show better correlation with microbiome. And in case of known diabetes, those who are diagnosed but are on treatment for a long time, factors like LDL, fasting glucose, cholesterol, and apolipoprotein B, these are the factors which show a good relation with microbiome. And relative abundance of certain phyla varies in the three categories, and the overall picture, if you see that in normal individuals there is a certain level of proportion of particular group of organism. When the person gets diabetes, that proportion is reduced, and after the treatment it somehow starts coming to normal, but it never comes back to the normal. So that is the overall observation. I mean, this is a new, so it disturbs, and after the treatment it tries to come back to the normal, but it never comes back to the original level. So that is a overall observation in almost all the organisms, for all the groups. And if you try to look at these populations again, three groups form distinct groups, and the predominant phyla that are affected by diabetic status are Prevotella and Bacteroides. In healthy individuals, you have higher abundance of Prevotella, which decreases in diabetic individuals, and reverse is true for Bacteroides. And this point is very important to note, because the studies that have been published from Western and Asian countries, they indicate that Prevotella is neutral, in the sense that many of these dysbiosis, Prevotella abundance does not change. Whether it is diabetes or obesity, Prevotella abundance does not change, and it is the Firmicutes and Bacteroides that changes. But in our studies, we have found consistently that it is Prevotella which is not only affected in diabetic and healthy status, but it is also affected in other diseases like obesity and IBD. Prevotella is the major group that is affected, and the general principle is that healthy status is associated with high abundance of Prevotella, and any dysbiosis, the Prevotella abundance decreases. So that is our general observation. We also tried to correlate variety of biochemical parameters with abundance of different genera, and again we found that Prevotella and Megasphaera show a kind of negative correlation with these parameters, and Bacteroides shows positive correlation of these parameters, which are markers for diabetes. And as I mentioned in the beginning, these studies are incomplete unless you may observe difference in abundance of certain groups of organisms, but the studies are incomplete unless you have some isolates in culture where you can actually study the properties of these isolates and also try to do some animal experiments and prove the hypothesis. So we had started doing large scale isolation of these organisms. The initial studies which were done on very small number of sample, one family, in just one study, we could get as many as 32 organisms which could be novel genera or species, and out of which so far we have published 4. So we have Megasphaera, Clostridium, these are anaerobic, and Pelistiga and Pantuia are aerobic. So far we have published 4, and again I'll come back and emphasize the importance of these studies. But the reason why these studies we are unable to pursue any further is we can do the isolations, we can characterize the organisms, but those of you are little bit aware of microbial taxonomy and associated issues would know that the today we are in a situation where this work cannot be published in journals, because there is a, whenever you are describing a new taxon, there is a requirement that the culture has to be deposited in the 2 international repositories, one within India and one outside India. And currently the way our biodiversity law is framed and the rules of National Biodiversity Authority are framed, no culture collection abroad is ready to accept the culture from India, and the cultures deposited in Indian culture collection are not acceptable to the journals that publish such paper. And it's a kind of, such regulations is a kind of alarming situation. I say this in all scientific forums where I make a presentation to warn the colleagues about what lays in future, because those of us who do sequence-based studies, metagenomic studies or amplicon sequencing studies, it's a requirement that the sequences be submitted in databases like NCBI and GeneBank, and very soon there is likely to be a ruling saying that if you are generating such sequences or you are generating proteomic data, that proteomic data also has to be deposited in the databases that are developed within India and not to the international databases where the journals accept. So we all should be aware of what lays in future, and if we do not take a proper hue and cry right away, what we are facing today, a broader scientific community will be facing very soon. So this is a word of caution to all the researchers. Unless we act soon, it's going to lead to be a very dangerous situation. So anyways, coming back to this, so I'll just show you representative picture of one of the genome sequences which we have done. And what is important, and the point to be emphasized here is that this was the isolate which showed very high similarity with Clostridium tunisiense at 16S rRNA gene sequence level, 99%. But when we looked at the entire genome, the genome had hardly any similarity between the two organisms. And if you specifically look at the genes that are involved in carbohydrate metabolism, you will see that the Clostridium tunisense has very small repertoire of the genes, and the gut isolate Clostridium punense has a very large repertoire of carbohydrate metabolizing genes. So the sequence similarity at 99% sequence similarity at 16S rRNA gene sequence level has no meaning in this case. The genomes are very different. So they are as good as two totally different organisms. So the 16S rRNA based sequence similarity does not mean anything in such cases. So that is a point which I want to highlight, and which is true fit with other isolators also. I am not going to talk about analysis of genome sequence from each organism, but all these gut isolates typically have a very large repertoire of genes which make them adapted to the gut environment. Of course, this is expected, but then in that case the 16S rRNA gene sequence homology makes no sense in such case. So based on that, then since we had a kind of lead in this study, recently we have submitted this proposal to DBT, and which has gone through one round of review, and it is under currently in the second review. So we have proposed to do a pan-India study inclusive of different, India has of course a very large number of endogamous groups. It's not possible to have all the endogamous groups for the study. So we have selected a major 90 endogamous group within India, and we have planned to map gut microbiome of 20,000 individuals across India, and it's a very, multi-institutional project. Such an effect cannot be done by participation of single institutes. So we have All India Institute of Medical Sciences, Christian Medical College, Vellore, then IBSD Imphal, ISST Guwahati, National Institute of Biomedical Sciences, Kalyani, and then the Foundation of Revitalization of Local Health Tradition in Bangalore, and Anthropology Department of University of Pune. So hopefully we will have this study funded, and within 2 years then we will probably have a more or clearer picture as to how gut microbiome varies across the India in response to various cultural practices, diet, and other factors that affect the gut microbiome, and I presume it will provide a very valuable information. And finally, I would also take this opportunity to mention here that November this year, 19th to 22nd of November, we are organizing international conference on microbiome, which will be attended by many major researchers like Karin Nelsel, Maria Carmen, who are working on gut microbiome, and also there will be some aspects of environmental microbiome also, and some key persons working in the area of plant microbiome and environmental genomics have also agreed to participate in this conference. These are all my different students, project assistants, and postdocs who have contributed to this work. Of course, I have not presented all the work. I have just tried to give you a overview of what we do, and this work again cannot be completed without collaboration with clinicians. So these are Dr. Bawdekar, Dr. Yadnik, and Dr. Makharia. These are my clinicians with whom I collaborate. Dr. Zuvekar is and Dr. Zuvekar and Shantanu, the picture is not here, but Zuvekar and Shantanu are the anthropologists with whom we collaborate. Dr. Ranade helps us in anaerobic work, and Seppo is the person who was involved in Indo-Finnish comparative study. Thank you very much. Yeah.
This presentation is open for any discussion or any question if someone has. I think there are a couple of hands raised right there. You will have to speak a little louder so that it reaches, or speak in the mic.
In the first study, where you compared Indian microbiome with the Asian countries, I would like to know the number of families that were involved in that study, or the sample size basically.
You mean to say the families from India?
Yeah.
So this study was done on 5 families, and average each family having 10 individuals. So this was all data, as I said, the data has come up from Vadu study.
Okay, okay. Sir, second question is that the Clostridium genome you sequenced, so was it a new species?
Clostridium punens, yeah, punens is a new species. Since it was isolated from an individual from Pune, I will named it as punens.
Okay, okay. So, sir, what was the ANI or DDH with the closest hit?
Since it was a draft genome and not a complete genome, we have not done ANI on that.
Okay. Sir, one very important and interesting finding that what was there in your study was regarding the megasphere, which can be associated with the Indian population.
Right.
So, do you think that the variation in overall the data you showed about that particular, I observed that was very much unique to India as compared to other Asian countries, including Pakistan, Bangladesh, and it may be because Indian diet is very diverse, and highest vegetarians of the world are here, and the rest of the Asian. So can we relate these two concepts in this case?
I mean, so the observation that megasphere is present in all Indian individuals is true. Now, why it is so, I don't think we have sufficient data to say why it is so, but again, that data I did not present. What we also did was that once we were the first one to isolate megasphere from human gut. Earlier it was isolated from rumen, and that we named as megasphere indica, and then subsequently we developed specific primers for megasphere, and we analyzed all the stool samples that we had from different studies, more than 300 samples, and all those samples were positive for megasphere. So which means that megasphere is present in detectable number in all Indian populations. Now, why it is present is very difficult to say. Probably it is because of the diet, or probably we have inherited it over the years, kind of it is co-evolved. That is something which we cannot say right now.
Okay.
I think we'll stop that here, and I am a co-chair and I have a question for you.
Just one comment, Dr. Shodi, in addition to this question, like when we talk about the major dominant phylotype in Pune, yes, you're right when you say that it's Prevatola. But again, when we have seen that in Delhi, in rural population in Delhi, urban population in Delhi, and plus we did the microbiome analysis from population in Ladakh, we found that firmicutes out there was significantly the most dominant phylotype. So obviously when we say Prevatola, yes, you have to specify the region along with that. Right. And once you do your pan-Indian study, then I think we'll be much wiser about it, that which is the dominant phylotype.
Thank you.
Before we close on this, I have two small observations which I would like to share with you.
Sure.
Maybe you have some answers for me. First is that you are talking of a national program which you are starting up. And I believe that we have a large number of parameters which you are considering in there. But I believe